Very much. You see, all inside is a very good asset, but we have to know that all these learning devices has to be there so that you comprehensively can repair your meniscus. I'll not go into detail, but all inside what I'm going to talk about is a very good devices. There are fantastic devices, available to us. It's easy to handle. It's, risk-free. But the only thing is cost. And then cost is very important in our patients, especially when they come, it is combination with the ACL. If your meniscal repair cost is going to be costlier than your ACL reconstruction, it will definitely cause problem to your patients. So cost is a big issue. But what is important, look at these systems, all inside systems available to us. There are two types of system. One is a peak-based, which are majority, the Biotech, the Smith & Nephew, these are peak-based. But don't forget there are other devices, which is MaxFire, pretty old one, and the fiber stitch, now popularized by Arthrex company. They are suture-based. And you look at this stuff, suture-based, it's very easy to make it. It looks like, ethibond there, and then some sutures are going here and there. So what they have is peak-based and the suture-based. And what is important is these are anchors, either it is peak-based or a suture-based. It is deployed into the capsule, and there is a self-tensioning and the locking knots. These are the two devices. And the cost is not of the anchors, actually. The cost is of the device which is used to deploy this anchor. That is what the 90% of the cost comes from for the all-inside devices. So that is why we thought that can we do the same thing with reusable devices so that it will dramatically decrease the cost. And that was the thought process when we started thinking of an all-inside repair device, which we published in Arthroscopy Technique and now getting lots of popularity. And I was able to demonstrate yesterday a live surgery of this one in which I was able to use the generation 2 of this AJ stitch. So what is this AJ stitch? It's a very simple. You have a 2.5 centimeter cut of 2 net bonds. Then pass this net bond through the 2-0 fiber wire, which is available, and then there are two anchors. Now, two anchors like others. Then we designed a device which has a slot, and it is a solid device. It is not cannulated. It has a depth measuring mechanism, depth prevention mechanism, and then what we do is manually we load. Manually we load, you go inside, put a cannula, go inside, fire one, it is just deployed. Then load another anchor, and then fire. It load. When you pull these two outcoming sutures, then the loop will go inside, and then you have to make a knot. This is the live, the earlier video demonstration of the same thing. This is the AJ device that we have designed. So it has a depth measurement and the depth protection system. So this is the cut we have made where you have to, hold your suture so that the sutures are tight, and then your anchor doesn't get dislodged into the joint. Even if it gets dislodged, you pull it out and load it again. So this is the loading. In the generation 2, there is another mechanism of loading which is much easier than what we have demonstrating out here. So this is the older device, my older video. So then again, the meniscal preparation is the same for all things. Either you do outside in, all inside, or inside out device. So one thing extra that we needed is the cannula. So we reuse this cannula. It is not much costly. So reuse this cannula. Then it is already loaded. And then go inside, find out the place where you want to, and just deploy your anchor. So disengage the sutures, take it out. This was the first one. Confirm your hold, which is required for meniscal repair. If it comes out there, let it come out so that you can pass in some other new places. This is the second anchor of the first stitch is being loaded. The same all process repeated. So initially it may look little cumbersome, but believe me, it is 10 times, 20 times cheaper than what we have. So we have been doing it for last, almost 14 months now. So this is, you see, anchor is being deployed now in the meniscus area, and then pull the two sutures, which is outside the cannula, and this will deploy the loop, which is going to repair the suture. One extra thing here in my device you have to do is you have to deploy the knot by yourself, 4 or 5 half hitches. So now we have come up with the modification of this stitch also, in which you can do a single suture, a deployment, a sliding knot that I demonstrated yesterday. So which is will be available for all of us to use. And this is, you can see that nice repair even with a very simple technique. So this came out of the mind that the money that we are spending on all inside is on the disposable material. Can we make it a reusable by a simple modification? So this is the second one. The first anchor goes, first anchor goes of the second stitch, and then you can come back, and then again the same, all inside, mechanism, but you don't need to give an incision on outside area. Many people who come for arthroscopy surgery, until unless you counsel them, they will not like to have a scar or incision outside. So that is the problem with my patient. And then again, you see, most of these meniscus are identified intraoperatively, and you have not counseled the patient. And then you go and say that you had a repair tear, I've given a big scar on your medial or lateral aspect, the patient will not take it very positively. So in that case, where you have not counseled, this device will come handy to your rescue. And you can see that the third stitch is applied. Yesterday in live surgery, I showed how 6 AJ stitch had been applied in practically, looking like a failed meniscal repair. And this is how it looks like at the end of the surgery with the simple technique. This presentation I prepared about a week ago. Now our count of the cases has reached 230. More than 400 anchors has been deployed. There are around 7% of the dislodgement of the anchor possibility. But as I say, in the factory made, if your anchor deployment is lost, your anchor is lost. Whole money is gone. Here, if the anchor has dislodged, you can take it out, fire it again in a better area where you have a better hold. There are lots of advantages like cost effective. It can be it can be made by using a local available material that you have. It can be performed with both observable and the non-observable suture. We did a small biomechanical testing also of this when I went to the biomechanical lab of the Singapore. We did a biomechanical testing, and believe me, this strength and the max fire strength are almost equal, because once it is deployed, they will act similarly. With this, I'd like to thank very much for this opportunity to briefly talk on this. Thank you.
Thank you, Dr. Amit, so for a wonderful presentation. Yeah.
So the current AJ stitch 2 is the handle that we are making is a reusable, but the needle has to be disposed, yes. Needle is disposed. But not all repair. If you start using Scorpio, you will understand that it's very difficult with that one. You need a good amount of the periphery. If it is a red zone tear, you cannot do that. You cannot use a meniscal Scorpio. So it has to be very limited type of tear in which you can use meniscal Scorpio. And the other disadvantage of meniscal Scorpio is the needle goes up, there is a chances of cartilage injury, And then when you use, you'll find out that all inside device is much handy, much easier, more precision of passing your suture where you want compared to the, this device. But I absolutely agree in case where, radial tear are associated, I also use a all inside technique with the Scorpio, yes. It is not possible. It is not possible. You have to use a Scorpio, you have to have a good peripheral rim. If your good peripheral rim is not there, the periphery bite of using the, whatever fast fix mini or the meniscal Scorpio is not possible. Yeah, thank you very much.
Yeah, thank you. Next is Dr. Naveen.